Remove his glasses and look at it.
My class, UTMS class of 98, has decided to make a difference in the country. We are scattered all around the world, but we've come together to do so many things. Recently, we came together and donated money for for the Holy Heart Festival.
No, they came together. As far as I can remember, that class must have been about 70 students. Right now, they came together. 2 of them came together.
And we have various specialists among us. There's a pediatrician who is in close link with the child health department, comes quite often to help them. And then some of our colleagues in the Western region who also need pediatric care. Today we are honored to have Dr. Yeboah. He's an assistant professor of cardiology in the Wake Forest Medical Center, to talk to us about coronary artery disease, pathophysiology, and multiple treatment pathways. After his talk, we will do another one that was at the bigger forum in the auditorium of the medical school, organized under the auspices of the UTMS. It's at 12 o'clock, so everybody is invited. These are the little steps we are taking to eventually break out, in a big way over here. Those of us in the UK, Ghana, US, and all around. So I present to you Dr. Yeboah.
Thank you.
Thank you very much, Dr. Entsua-Mensah. My name is Joseph. I trained here. I can see some of my mates. Was coming on vacation this month and decided to come and see some of the wonderful works that are being done here at the CTU. And I thought we could have some exchange of ideas this morning before I look around to see the excellent work that was being done. I was told this talk is 20 minutes, so it will be short. I'm also told that there are medicine and surgeons here, so I had to choose a topic that will sort of overlap so that everybody can see. So my title is Coronary Artery Disease, Pathophysiology, and Multiple Treatment Pathways. This will be sort of a revision because I'm sure most people here know everything, but some of the treatment pathways are different if you move from Germany to England, or if you go to the US, so there may be some variations. I will start, but you can stop me anywhere if you have any questions, and then I can try and explain. I have nothing to disclose here. This is what we're talking about. We're talking about coronary artery disease. It happens to be blockages in the arteries around the heart. The underlying pathology here is atherosclerosis. We don't know what caused atherosclerosis. In other words, we don't know any bug or what actually causes it, but we know risk factors that are associated with the disease. So we know that if an individual has these kind of risk factors, they are more likely to have the disease. The first and the biggest among them is age. In fact, if you look at models predicting who is going to have clinical atherosclerosis, age contributes more than 50% of the prediction model. Male gender is also another big risk factor for coronary artery disease or atherosclerosis. It's said that a male has 3 times the risk of having the disease in their lifetime compared to a woman. Hypertension, a big thing here in this country, is also a risk factor for atherosclerosis and coronary artery disease. The treatment of hypertension is known to reduce the risk of this progression of this disease. Diabetes is also a big one. Notice that I've had question marks there. It turns out that having diabetes per se is a risk factor for coronary artery disease, not so much the sugar that goes up. Because we've done trials where we beat down the A1C so low and we still can reduce coronary artery events, even though we can reduce nephropathies and retinopathies in these individuals. Cigarette smoking is another one. Cholesterol, which is now taking the center stage since all the monies are being made in this arena. Family history, obesity is also a question mark. It's a question of whether obesity works through either hypertension or diabetes, or whether it by itself is a risk factor for having this disease. And there are a lot of novel risk markers that are coming on board. Stress, inflammation, you can hear what have you, all in the name of us finding the cause, what actually makes people have this disease. Now, if you look at the pathophysiology, we're going to start from here and work our way down here. Supposedly, we're born with clean coronaries. If you take the baby's coronary and you take a cross-section of it, there's nothing within it. But before the child is about 14, 15 years old, you start seeing fatty streaks in the coronaries. They begin to develop the disease. Then the endothelium first gets damaged, and then lipids get deposited in the wall, and then all of a sudden, a plaque forms. Now, body, whoever made us in such a way that when this happens, the artery remodels. It tries to maintain the size of the lumen. And so there's a phenomenon called Glegoff phenomenon, where you have a plaque of about 20 or 30%, and the type of 20 or 30% tends to protruding into the lumen, and you will see the artery dilate so that it still maintains 100% of its lumen. Now, once beyond that point, three things can happen. One is this plaque will grow slowly, and the person can live its natural life and be killed by something else. And so the person will never have clinical cardiovascular disease or clinical disease. And another pathway will be the plaque can grow and slowly occlude the lumen. And so you see that you have these fibrous thing growing and growing and growing and growing, and then finally it blocks the whole vessel off, and then there's no supply distal to it. Now, the more aggressive one is you have the plaque, you have a lot of rich stuff in it, and for some reasons less known to science at this moment, the capsule here ruptures. Now, when the capsule ruptures, endothelium is peeled away, and when endothelium is peeled away, collagen is exposed. When you expose collagen, platelets hone in. And so you have a lot of platelets coming in to attach here, and all of a sudden a vessel that looks like that, and the lumen is occluded. So these are the three clinical scenarios that can occur once a plaque is formed within it. And these three clinical scenarios present themselves clinically in the way we treat this disease. Now, I said we had this pathway which we call the old paradigm, where we thought that, okay, this is a vessel, the lumen is open, it gets narrower, 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 and then it's blocked. Now, the other one is you have a plaque there, you think you're fine, this is a 20-30% lesion. Now, it grows up a little bit, something happens, there's erosion or something, it bursts open, collagen is exposed, and then this also gets occluded by a plaque. Now, notice that this is a platelet-rich plaque, because when you expose collagen, what tends to happen is when Willebrand factors goes in there, then platelets goes in there before thrombin comes in. So this is a platelet-rich one. Now, because of these two pathways, there are two clinical scenarios and two disease syndromes that we can get for coronary arteries. Now, if you happen to go through these pathways, these are the clinical diseases that you're likely to come up with. You either have angina or you present to us with cardiomyopathies. Now, if you happen to go through these pathways, and it's not one or the other, you can go through both at the same time, because you can develop these diseases in all vessels. You can either have an ST elevation MI, or you can have non-ST elevation MI. So I'll walk you through one of each, and then we'll see how they present and how the treatment pathways differ in terms of treatment. And the first one is ST elevation MI. ST elevation MI, as you recall, I said, is due to plaque rupture. Usually these occurs in individuals with about 30% lesions or 40% lesions. So If somebody had a heart attack today, if you were to see that person yesterday and send him to the CAD lab and look in that person's coronaries, you probably wouldn't see a 90% lesion there. You would probably see a 30-40% lesion. That something happened, the plaque ruptured, it ruptured, platelets got aggregated, and then the lumen got fluid occluded. As I said, it's usually from a non-significant lesion. In the US or in the Western world, and I'm sure it's also here, we always call this time is muscle. And that is, the vessel is acutely occluded, the muscle is dying, the muscle is initially stunned, but if you leave it for a longer time, it will die. So there's an urgency here to take that person and either open it one way or the other. Now the diagnosis here is usually made by clinical presentation and ECG only, because we have to make the diagnosis as fast as we can. We don't wait for biomarkers, and most of the time people go to the CAD lab, but this is not the only way of treating it. Years and years ago, we were only using thrombolytics to treat it. Now it turns out that within the first 3 hours, there's not much difference if I give you a thrombolytic or I send you to the CAD lab to put a stent in your heart. So what we do, and that comes back to the door to the balloon time, is if you present with this kind of scenario in the field and you're not close to where a CAD lab facility is, the chances are that if you are not within this time, that is when you hit the ED is the door, and the balloon time is when the balloon goes up, and I'll show you a picture of that. If we think we're not going to make that time, you will be given thrombolytic and then sent to the next nearest hospital. If we think you can make it, then you will be sent to the CAD lab. Or if you present to a facility that has the CAD lab, then you will go there straight away. So yes, there's a role for thrombolytics. We don't need to have CAD labs all over the place. It's only when you present later, beyond 3 hours, that the benefit of thrombolytics fade away, and therefore we don't tend to give them. So let's look at a case that I treated. So it's a 50-year-old male, history of hypertension, hyperlipidemia, and smoker. He awoke in the morning as usual with left-sided chest pain, shortness of breath. He took some antacid, as everybody does. But there's a notion out there that if you take antacid and it doesn't go away, take aspirin before, because maybe you are having a heart attack. So this person took aspirin, which was very good. He then called 911. Emergency people got there in 10 minutes. Usually when they get there, they'll give you nitrate. They go through emotion, morphine, they just try to let the pain go away. They do an EKG. Remember I said here that the diagnosis is made by clinical presentation and EKG, right? So we'll be able to make the diagnosis even in the field, because they do an EKG over there before they transport that person to the hospital, cutting down the door to balloon time. So some people can activate the CAD lab from the field because they can fax the EKG to you, and you can look at it and say, yes, this is an ST elevation MRI. And so he was sent to us for treatment. This is the EKG that we got. And as you can see here, look at 2, 3, and AVF. You see those tombstones over there. High ST elevations here, and these are reciprocal changes in 1 AVL and also in V1, V2, and V3, showing that there's an inferior wall MI going on. Based on this and the clinical presentation, the diagnosis is made, and this person needs to be treated. Now, at this point, if the person is in the field, the question is, how close is the next CAD lab? Now, if the next CAD lab is closed such that the person can get there and the balloon can go up before 90 minutes, then this person goes to the CAD lab. If not, we will ask them to give the person thrombolytics and then send the person to us. So this is this guy's CAD lab. But before that, getting there, we usually give them aspirin, we give them 2B3H, which are Plavix, Paracetamol. They are newer agents of the market. They also get heparin. This guy was lucky. He sort of reperfused a little bit before he got to us. You can see this is the right coronaries, and the shock through the in the right coronaries. We see the obstruction there that caused the lesion. Usually what you see here is a stump. This whole part of it is not there because it's fully occluded. And then you go up and then you open this up for the person. The next one shows when the balloon goes up. So the wire isn't there, and the balloon is up. We're trying to open up the artery, and then this is the finished product of what happens to this guy. He gets a stent, the lesion gets opened up, and then these individuals usually stays with us for 2 to 3 days in the hospital before they go home. Now the problem with them But